we'd like to make sure we're covering both learners here in the audience today. And we got a great group of surgeons up here. So if you're a bariatric surgeon, you came in here with an idea or a question, ask it. Let's get these guys to work. If you're a covering doctor and you're concerned about things, again, there's no question you can't ask. We just need to do it within 15 minutes. So any questions from the audience? Yes. Introduce yourself, please.
Alay Tohami, I'm from Philadelphia, a bariatric surgeon. I have a question about the leak on sleeves. Have you guys didn't mention on the lecture about using sealant, like the surgical sealant, whether it's Evaseal or T-Seal, and also reinforcement the staple line of with the suturing, whether with the omentum or the short gastric wear, or whether just using the stomach as imprecation.
So question on sleeve, I think it had to do with oversewing your staple line?
Oversewing and using the sealant as well.
So what do we do for that staple line? Do we sew it all the way down? Do we just sew it where it's bleeding? Do we put some glue on it? Do we use the strips? What do you guys do? Let's go in order. Sam?
We oversew and we oversew.
With silk or absorbable suture?
We use reabsorbable Vicryl.
Vicryl. Bruce?
Vicryl.
We don't do anything.
Do nothing. Scott?
I use buttressing material. There's 2 studies that I'm aware of that show that oversewing increases the leak rate.
Mike?
Use the 3.0 Maxon V-Lock sewing.
Ooh, fancy. Raul?
I do what Sam says. We oversew.
What does Sam do? All right. Does that help answer your question? Good. Next question.
Sorry, one quick thing about that. In the latest consensus, they recommend doing something about the staple line. It's either buttressing or either oversewing, but you should do something about the staple line, even though at this point, about 30 to 40% of the surgeons still don't do anything about
Bruce, how do you do nothing? I mean, this bleeds. Don't you get some bleeders?
Pretty rarely.
Wow.
So, I mean, if we get a bleeder, we'll put a figure of 8 stitch there.
What if you see a big blood vessel coming in?
I used to oversew the whole thing, and now I've gotten away from it. We haven't had, we tend to use a little bit larger staple height, so I'm not as worried about a leak. And I think the biggest technical problem you make is if you make the anti-shear too tight, you make it too high a system, that's when they get the leaks. And if you don't make that too tight, you can make the top of it tight, but just don't make the anti-shear tight, and you do okay.
I'm also unaware of any data, I don't know if anybody else on the panel is, of the use of sealants having any benefit.
So we have some other questions that you guys have texted in. One is, how soon after an operation would one consider dilating a strictured sleeve? So we just put them on liquid diet for 6 weeks, or can we just dilate it sooner? Or?
I will do it just as I do with the gastric bypasses. Our patients stay on a liquid diet for 2 weeks. At that point, it shouldn't be a problem unless there is really marked dehydration, repeat admissions for dehydration, then you might be aggressive. If patients are tolerating liquids, and right now, they usually didn't tolerate the thick protein shakes, but now you have powdered proteins that you can put in any clear liquid. So even with that, you can stretch this as much as you can. Again, some of them would markedly improve. So I will do that. Once you introduce the pure diet, if there is some difficulty, then we start acting. But I will say no less, at least 4 to 6 weeks, I will hold if the patient is tolerating liquids with no difficulty.
Question in the front.
This is regarding sleep apnea, Dr. Sikora. Now, if the super obese patient, if you give them intragastric balloon and reduce the weight by 10%, that reduces the risk of postoperative complication in the sleep apnea patient.
Did you catch that?
Intragastric balloon before surgery.
A balloon before surgery.
Balloon before surgery.
You mean an arterial
A sizing
cardiac?
balloon?
Intragastric balloon. Bioenteric balloon for the through the endoscope, reduce the weight.
Well, they're not FDA approved in the United States. They are used elsewhere. I know that articles about preoperative weight loss with balloons, and anything that causes people to lose weight preoperatively, I'd be in favor of.
I did it actually. I mean, few patients, it really reduces the risk, and patient happy. Even 10% weight loss, it reduces the risk of the patient.
Absolutely, I agree.
Question in the back.
Alex Sonomchenko from Atlantic City. I'm a bariatric surgeon. I have a question for Dr. Schweitzer about type and timing of VTE, chemo prophylaxis for VTE. Have you seen any data about difference in transfusion requirements between the different chemoprophylaxis agents, the timing of them? And I know I've noticed kind of a second case bleeding phenomenon. Well, that second case seems to always bleed more than the first case. What's going on there?
You said the timing of using oral anticoagulants.
And the type. For example, I'm drifting back to basic sub-Q heparin away from enoxaparin because it looks like that's going to diminish my transfusion requirement, even though I'm only transfusing about 4% of sleeve or bypass patients.
Well, let's find out what the panel is using for their bariatric surgery. So let's go down the list. What are you doing for DVT prophylaxis, Sam?
We're using sub-Q heparin on the first 24 hours, and then we switch to Lovenox for the rest of the admission.
And you continue that post-op or stop?
No, we continue post-op until discharge.
All right, Bruce?
We use Lovenox in addition to boots and ambulation, but we will continue the Lovenox after discharge on the high-risk patients.
And you continue that for 1 month?
Very high-risk patients a month, moderate-risk patients with basically leg edema, bronch edema, 2 weeks.
What dose?
We vary it by weight, anywhere from 30 to 60.
Scott?
Generally unfractionated heparin, boots, early ambulation, high-risk patients, I send home on Lovenox for a month.
Raul?
Same as Sam.
Mike, who's correct?
We don't know the answer to that.
The
I will
microphone.
say one thing about the oral anticoagulants, if you send them home on it, the insurance companies, the pharmacies charge a lot, even for generic Lovenox. It can be up to $900. The markup is incredible. So the oral anticoagulants only cost $160 a month. So if the patient self-pay or can't afford the pharmacy part benefit, you may want to think about it if they're high risk.
Does ASMBS have a guideline that says this is the right way to do it? And Scott says yes. What is ASMBS saying today?
ASMBS recommends chemoprophylaxis along with the use of mechanical, which are the boots and early ambulation. They have a white paper, it's on their website. But I wanted, if I could ask Mike a question. There's at least one paper by Ronnie Clements and possibly more than one that demonstrate that the chemoprophylaxis adds no benefit over mechanical. How do you feel about that?
I think you have to be careful if you're talking about clinical versus asymptomatic clot. And we'll see how the data falls out, but getting iliac vein thromboses, whether it causes them a PE that time or on the next surgery, is significant.
Does anyone use a filter? Raul, you'll put a filter in? Bruce?
And I think in the patients who have an inherited genetic and a previous history of PE, then I will. But it's probably 2% of our patients.
Mike, does the data support that?
I still use it. The data does not conclude, but it definitely filters increase clotting. So I think you still have to use Lovenox or whatever extended.
Sam?
I think it's important, not only we use it in the super obese patients and patient high risk, but also if you're going to send patients home on Lovenox or any other treatment, you have to be very careful to follow the guidelines of that product. Because it's not, let's send it for 1 week. Don't make it an eyeball judgment. He probably will benefit for 2 weeks or for a month. Make sure you read the indications for that product and the length that you should do it for prophylaxis, because you'll be exactly liable if something happens.
What he means to be saying is the lawyers do read those guidelines.
There's no FDA guideline for that. Most of the companies don't have FDA guidelines.
They have a package insert.
Some of them do for the use for prophylaxis.
And if you start to get some bleeding in your post-op crit, are you okay turning off the heparin? Everyone's good with that. So that is probably less about turning it down before you bleed, but we feel good about turning it when bleeding occurs. Next.
Yeah, I'm Ratna Palapathu from upstate New York. 2 questions. About patients with sleep apnea, when is the best time to start the CPAP? Is it you start it on the day of surgery or you wait for 24 hours? And the next question is regarding the size of the linear stapler. I know there's no clear data. What do the panel think? Which is better, 45 or 30 linear stapler for the anastomosis for the GJ?
So first question has to do with, can you give CPAP in someone with sleep apnea immediately after surgery, or do you wait? Scott?
I've done it in the recovery room, hour or so after surgery, and like I said, the whole thinking that it's dangerous to do it. If that anastomo was going to leak, it would have leaked anyway. It's not the CPAP that made it leak.
So this has been studied by Ed Livingston, showed clearly that using the CPAP is better than not using it, and that this idea that we're going to blow apart our anastomosis at least doesn't have data in his studies. Other comments on sleep apnea?
Well, we published about that about 4 or 5 years ago. And
So I
again,
should have quoted
from
your
our
paper
experience,
first.
You can use it. You can use it immediately after that, and actually will benefit. No incidence of.
And the second question was on staple height?
Yeah, is it 40, for linear staplers, is it 45 or 30? What does the panel think? How does some people use 45 linear staplers, some people use 30. What's the general consensus on it for the linear stapler?
Stapler links are 30 and 60. No one I know
45
uses
and 60.
45 and 60, so I don't know anyone using 30 for most sleeves. And I think what
No,
the guys
I'm saying for gastric
for
bypass.
gastric
when you do the
bypass, most guys were
gastrojejunectomy.
using 30 or 45.
You're talking about the
Gastro-J?
Gastrojejunectomy.
And I think we saw today you guys were using 45,
I use a 45.
45, and a bigger anastomosis.
We use 45, but not the whole staple. 3/4 of the staple in.
All right, question from the audience wanting to know about Botox. You always wonder if that's a sales rep. So Botox with leaks. Any experience with this?
I wouldn't give it to myself. If that's
Well,
what
you're too
asking.
pretty.
And I certainly wouldn't give it to the patient.
All right, next question. What is preventive measures for portal vein thrombosis? Okay, board question. Scott?
That's a very, very interesting concept. That's starting to show itself more and more with sleeves. We just had a patient transfer to us with portal vein thrombosis and actually bowel necrosis. I'm not sure what you can do about prophylaxis. I'm not sure what the exact etiology of it is, other than it must be related to taking the short gastrics.
Raul?
Yeah, I think hypercoagulable states, obviously, and dehydration are risk factors in patients for portal vein thrombosis. And the key is the treatment, what you do with them. And from my reading, what I understand is if they are asymptomatic, you anticoagulate them, you put them on Coumadin, and you observe them. But if they become symptomatic, then you do a transjugular lysis of the thrombus. And there's been a very nice paper written in Obesity Surgery about that with a large series of portal vein thrombosis.
It's a much more prevalent problem with splenectomy.
We have a bunch of questions related to the size bougie for a sleeve and how you prevent kinking it off. Sam?
Size, again, we use 38. Studies have shown that below 40, you will lose more weight than above 40, but again, the smaller the bougie, the greater the chances of leak. How to prevent kinks? You just have to be careful, not make it too tight. If you see blanching when your stapler is close near the bougie, you should just open it up.
So you're
slide
you're
it out.
using a 40, but you're cheating off as well.
A 38, but cheating off
38
as
and a
well.
cheat.
But remember, we imbricate when we close.
Bruce?
We use a 32, but again, we're real careful around the anti-Shura not to get too tight.
Does real careful mean you cheat to the right?
Meaning, don't get too close to the bougie.
Okay, Scott?
I do what Sam does.
Raul?
The tighter the sleeve, the more the leaks, the more the stenosis. So I do what Sam does.
All right. All right, Mike, would you dare do anything that Sam doesn't do?
Running for office today.
Absolutely not.
All right. Any other questions from the audience? Yes.
Yeah, can you talk about the time, sorry, Chris Lee, Baltimore. Can you talk about the stenting for early leaks after sleeve? How long do you leave those stents in? Because you can't leave them in for, more than say 4 to 6 weeks. Do you re-stent them after that? How do you manage that, please?
So the question is, you have a small leak after a sleeve. Can you watch it? Do you need to stent it? What's the
I'm
management?
saying if you stent it, how long what's the management?
Right.
How
So
do you manage the
do you stent, and if you stent, how long, Raul?
Oh, well, we didn't have, thank God, to stent leaks. We had one at the very beginning of our experience, and we observed it, laparoscopic drainage and jejunostomy, and went very well. I think the key is you can stent if you want to, but after 12 weeks, when patients come with those leaks for 6 months, for 8 months, or for 1 year, stenting has no role. In the acute phase, if the patient is hemodynamically unstable, take him to the OR, lavage, drainage. If it's a large leak, probably stenting makes sense. If it's a small leak, I don't think you need a stent. Remember that stents create problems also. They migrate. Sometimes they engraft so much into the tissue, you cannot take them out. So the answer is before 12 weeks, you can play with those. After 12 weeks, you should forget them.
Scott, what type of
Yeah,
stent
but
are you using?
How long are you going to leave them in for?
What kind of stent and how long will you leave it in?
We've been using just the interreflex stents. We've had a miserable experience with stents. I don't think we've had much success. We've had a lot of migrations. Patients complain of significant pain with the stents in place. I favor what Raul was suggesting, which is drainage, antibiotics, a tincture of time for most small leaks.
So vote against stents, Bruce.
We've only done it a couple times, but I would say that it really depends on patient tolerance. If patient's tolerating it well, we've left them in for a month. No tolerance, obviously a lot less. We use covered stent.
There is a paper, I think, on the meeting later that talks about stents and experience with about 40 stents, so we'll see that later on. Well, I think they got referred to him. It was Dean's. Well, with that, I'm going to conclude this session. We're going to take a small break, and we'll be back at 10:15. Thank you for your participation.